All right. Hey, everyone. Welcome back to the Sanity and Society podcast. I am here with my guest, Valerie Vallador. I am so glad to have her here. I encountered her on Instagram and just loved her content about what it's like to be a modern day psychology PhD grad student. And there was all kinds of aesthetic posts and also some really heavy content about what the workload is like, what she's doing. Welcome, Valerie.
Hello. Hi. Thank you for having me.
Of course. So I think we might have met on Threads too, potentially, when I was talking about having guests and things.
Yes. Yes. You had posted, it was my first day on Threads, and
Yeah.
you had posted one of those, I want to connect with people, XYZ interests. And I think the good thing about the platform is using your voice to get content to people that normally wouldn't find it, unless someone put it out there. And so I just played into that.
Right. So one of the things that I think it's important for people to understand is when you go into the psychology profession, there's a lot that's entailed in learning how to develop models, and it's not just how do you feel. There's so much more to the psychology profession. It may be called a soft science, but there's definitely a lot of hard learning and theoretical models. When did you first discover that you loved psychology?
I have the cliche experience of taking AP psychology in high school and finding just the understanding of behavior very interesting. And then the brain behavior connection very interesting. And as someone who just really highly values health, it kind of started to play into that value. So I really, I think, had the passion kind of explode when I was a group fitness instructor, and having a lot of people that I taught group fitness for physical health kind of coming to me after the class, talking about the language I used in the class and how that spurred motivation and coming back. And then it was more about that brain behavior aspect that I was like, oh, you know what? Psychology really is the bee's knees, like the bee's knees. Like, let's talk about how to get people in here and feeling like mentally good, not just physically good.
Right. No, that's great. And I love that you bring up that overlap, because we now know that there's such a body and mind link. We're not just brains in a jar. Our body's not just this vessel, but it overlaps so much with our mental health. So you developed that awareness pretty early on.
It would seem so. It would seem so.
Yeah. So where are you attending school?
So I'm currently doing my clinical psychology PhD at Eastern Michigan University, which is in Ann Arbor, Michigan. And, I've traveled far for this degree.
Yeah. Where are you originally from?
Miami, Florida. Pretty different in every way possible. Yeah.
Yeah. The weather, right?
The weather, the access to croquetas, the beach seasons,
Yes.
So very different, just in every regard.
Tell me really quick, what is a croqueta? Remind me.
So croqueta, it's like a Cuban pastry. It's kind of a ground up meat. It's ground up with flour to create this kind of paste, usually ham. But it could also be chicken or bacalao, which is a type of fish. And then it's coated in this like light breadcrumb type fixture, and then it's fried. It is maybe not the best for heart health, but it's really good for the soul.
Yeah, being a Southerner, I absolutely love fried food. So you kind of win me over with that alone. And then the fact that it's like baked in flour, that's great. Fried in flour is just
delicious.
Yeah. So tell us a little bit about what you're studying degree-wise. What's your PhD in?
Yeah, so my PhD, I will say it's a scientist practitioner model, meaning that my training focuses on research development, but also my development as a clinician. Ideally, there is really close tangential relations between the both, but I will say my research and clinical work is slightly different. So regarding research, I do more My area is more so body image, family systems, and supportive communication. And so right now I'm in my dissertation phase and I'm doing a coding project looking at how messages of acceptance and challenge can foster positive body image in adolescent girls. Um, and I'm looking specifically at mother-daughter relationships to kind of assess and code for this. Now, clinically, I'm still interested in family work, but I tend to work more with children and adolescents. And I'm very interested in executive dysfunction and emotion dysregulation. And it shows up transdiagnostically. So
Mm-hmm.
I do a lot of work with ADHD, anxiety, and depression, and whichever conglomerate of those issues might come because of the high comorbidities.
Spectacular for listeners. So executive dysfunction meaning your frontal lobe is not activating, you're not doing as much stuff cognitively effortfully. Is that kind of what we're talking about?
More so in regard to the higher order cognitive functions that
Right.
you can tap into in a test battery, for example. So
Okay.
another part of my clinical work that I've really deep dived into is neuropsychological testing. And so when I think of executive functions, I'm thinking about processing speed, working memory, and these are the kind of higher order thought processes that allow people to problem solve, to plan and organize. And when people lose that, or when kids are struggling to develop that at the same rate as their peers, it creates, a lot of room for
Mhm.
feeling different and mood disturbance. And even has a role in that mood disturbance because they can't problem solve the thing that's frustrating them. And so this is an area of work within children and adolescents that I'm just extremely passionate about.
Yeah, that's wonderful. And you plan on, after you graduate, working with them clinically, doing tests and therapy, or what do you see as the outcome? Yeah.
So right now I'm in the process of applying to internship, which for psychology PhD students is essentially the equivalent of residency. I would like to be in a hospital or academic setting where I can do therapeutic intervention and assessment. I think there's a really amazing
Mhm.
bridge between assessment and intervention where you can go into intervention knowing the cognitive profile, aka their strengths and weaknesses, which allows you to better tailor the intervention for that kid or that family's specific need.
Yeah, I'd love that. I mean, really what you're doing is the best possible treatment planning by doing all this testing and then knowing where to intervene versus something that's maybe shorter or just asking, why are you here? So it's
Right,
so cool.
right. I will say it really shows up within the complex clinical presentations I've worked in, it really gives you a direction.
Mhm.
Because as many young clinicians might come to understand, there's always going to be the evidence-based practice recommended
Right.
for a certain concern. And at the same time, there might be individual factors that can vastly influence whether that intervention is actually appropriate for them. I did some psychological testing recently as in the past 6 months, where the kid or young adolescent really was struggling with conduct and
Mhm.
executive dysfunction and oppositional behaviors and depression. And DBT was seeming like the best route, but cognitive testing revealed that they had borderline intellectual functioning. And it was
Uh,
really hard to flag for it because their verbal comprehension, their verbal skills were actually quite high in a way that compensated for their other cognitive functions. And
okay.
so, really, something as abstract and nebulous as dialectical behavior therapy
Mhm.
would not have actually landed as well as would be expected for maybe a neurotypical child.
Right. That is fascinating. And you wouldn't have known that stuff without the testing. You wouldn't have known that they were compensating with verbal.
Yeah.
Wow. Okay.
A lot of jargon there, but basically, individual needs can be revealed with testing and
Yes.
that.
No, that's great. I think that's a really useful illustration, though. Okay. So, what do you think are some some things you wish you'd known before going into grad school for people out there who are interested in studying psychology academically?
Everything.
Okay. No, I like that. Such as?
So I'll start with I think the lack of advocacy that there is for students.
Mm-hmm.
I think that there's something to be said about the fact that PhD is associated with prestige and flexibility and financial stability because you're a doctor and less than 1% of the population holds that degree. And
Right.
what they don't tell you is that while you're in the process of earning that degree, you are not only at what maybe baseline for most people, but just the complete opposite. There is no flexibility.
Right.
There is no financial security. There is no stability whatsoever. And what's hard about that is a PhD in and of itself is very demanding, but when you're strained for resources, it makes it that much harder. And sometimes it can feel like a bit of just a test to see if you'll get out versus an environment that will give you the space to flourish and really explore your passion, right?
Right.
One aspect of this is especially in clinical psychology, is that each year you need to do a practica. And so each year you're applying for the next practica, even if you've only just started your current one.
Right.
And
Wow.
so,
What's that
so
like?
well, I think that it can be very challenging for people to end a PhD with a sense of direction because it's so easy to get pushed in one.
Absolutely. So, what do you think, what keeps you grounded in that and recognizing your direction versus what you can kind of feel pushed into?
I think perhaps because of my clinical repertoire that I love acceptance and commitment therapy and dialectical behavior therapy. I really believe in the strength of mindfulness. And so much like a hurricane has like a little eye, I try and find my way into the calm within the storm to think about what is it about this thing I did that I liked? What is it that I disliked? And finding some space for reflection and talking about it with my mentor. I will say that this is something that any person interested in a program needs to know. Your advisor can make or break you. Having a good advisor who will listen and also advocate for you when the program does not will make your whole experience so different, because they can also either be the person that pushes you into the current or the one that will throw you like a little flotation device and be like, let me pull you out so we can talk.
And that's one of the things you'd said when we were planning this podcast is like, you're not applying to a program, you're applying to the faculty. Say a little more about that if you can.
Yes. So with the research emphasis of PhD programs, you are expected to develop as a researcher. There's a lot of research out there. And so if you're trying to become the expert in your field on a certain topic, you need to be mentored by a current expert in the field in that topic. And so with that, you're looking at the person who's going to advise you rather than the school name in it of itself. And so an example that illustrates this is, as someone who enjoys family systems work and child and adolescent work with my established interest of body image and communication, I'm going to apply to X school with an advisor who does body image and family systems work. I could apply to Harvard because I like the name. Oh, Harvard, that must be great. That'll look so good. But their whole faculty might be focused on more geriatric research or be more focused on depression or behavioral health. And I'm not trying to become an expert in those things. So not only would it be a disservice to myself, I probably wouldn't be a good fit for the program and they probably would not take me in the first place. Not because of skill level, but because of interest.
Right. I think that's important for people to know. If you have a really strong interest looking at programs that are tailored to that. Another thing that I think would be awesome for us to chat about is how therapy training, how psychology training teaches you to be more than just like an expert coffee date. We'd said. I'd love to hear more about that, like what the difference is between talking to a friend and talking to a psychologist.
You know what's funny about this is when we talked about this last, I had pretty strong feelings about it. And since we've last spoken, I've had 3 new clients on my caseload who've come in saying that their last therapist felt like a coffee date and there was just so much, they were stagnant.
Right.
So how ironic. But anyhow, the way it's different, coffee dates with your friends, they're great. It's good to vent. It's good to get things out. And yeah, the difference with doing this in therapy is that a therapist is trained to analyze patterns, to consider processes, to consider based on their theoretical orientation, how this aligns within a certain model of either something like values systems, which would be more of an act-based therapist,
Right.
versus, kind of this like functional analysis of contingencies. Someone might be more psychodynamic and look at how a certain behavior fits into an attachment style. And someone can be integrative and consider all these different factors. But the point is that with therapy, you're not just releasing, you're getting
Right.
a reflection.
That's powerful. Okay. Love that. And we know from research that venting doesn't always result in a release. It can make people angrier over time. So there's very interesting study on that in itself. But that notwithstanding, I mean, so venting itself, like maybe go with your friends and discussing things, but sometimes friends are incentivized to tell us what we want to hear. Maybe if they're people pleasers or they don't want to hear the conversation at the time, or they generally don't know what to say. And so you might not get the kind of resolution from just another set of ears for a friend that you would from someone who has been trained in how to be more objective, who knows that sometimes you might not like what they have to say, but if it's ethically and empirically founded, then it's better to hear that than something that's more placating or, yeah.
Yeah. And I think what you say about the placating, I think about enabling.
Yes.
Sometimes, I like to think about the fact that you can have a coffee date with a friend who is going through the same thing as you, and that can be very validating. You can
Yep.
have a coffee date with an older person that maybe you respect and has wisdom, and they can reflect the way maybe a therapist would with their life experiences. But what a therapist is doing is they're taking the research, they're taking the literature, and they are looking at what you're telling them through that lens.
Absolutely. Love that. So they're really doing applied scientific work.
If they're doing a good job.
Yeah. Bingo. Oh, the conversation about like, how do you feel therapy? How does that make you feel? That's a great place to start, but where do you go from there? Like, I love that you brought up psychodynamics. I love to do attachment work with EMDR therapy and get into that model of attachment styles or polyvagal theory, ego states work. You got to know what you're passionate about in the field. And you do that by shaping, by going a little bit like dipping your toe in, seeing what resonates with you. Speaking of, what enlivened your passion for ACT and DBT?
Well, there's maybe I'd say twofold reasons. One is that I think, how do I put this? One thing I really love about ACT is that it can aim to mitigate anxiety or depression. It's a transdiagnostic model. It can really mitigate whatever's happening from a standpoint that we can't control everything that's happening. And I think
Right.
that as a zeitgeist, everything that's happening right now, there is reason to be stressed. There is reason to feel
Sure.
anxious and to maybe have a little sense of hopelessness. There's a lot going on in the world right now that is beyond our control. And I really love that the center of ACT is, how can we live a meaningful life in spite of that? How can we think flexibly enough that even if those things are present, we can still have a quality life. I love that because it's true. We have to learn to operate within the context of what the world is right now. And then with DBT, similarly, it kind of addresses thought repertoires in a way that helps you relate to the world differently. I became familiar with DBT while working in an inpatient setting. And the worlds of individuals who are often in inpatient settings are very chaotic and very confusing. And as a clinician, I can't change the world that they came into.
Right.
But I can try and support them in how they relate to their thoughts about the world. That's what I love about active DBT.
Bingo. Love it. Yeah, I resonate with those two. I'm actually doing quite a bit of ACT work these days. The overlap too with ACT and DBT is amazing. So with acceptance and commitment therapy, acceptance is in the name, right? Like you're learning to accept what's occurring, reduce the labels you put on it. And with dialectical behavior therapy, there's a whole part of it called radical acceptance, which is not radical approval. It's accepting what's happening, just saying this is happening. I'm not going to be in denial about it. I'm going to, as a first step, accept it. So now, I mean, people out there listening can even think of what kind of therapies to potentially ask for that have some actual structure to them and some philosophy, because that's really what's lacking in directionless therapy is a philosophy of change. How do we change and what does it mean? Versus what's the crisis of the week?
Which sometimes that's how therapy is too.
That's true. And at least we can have a model to run it through.
Yeah.
So what got you into posting your content on Instagram? Let's dive into that, because that's where a lot of people I think are going to know you from, is your very cool, aesthetically neat posts.
Thank you.
Yeah.
I got on Instagram for a few reasons, but with that fact that I moved from Miami to Ann Arbor, I was experiencing a lot of displacement and just a lack of community. One thing about the PhDs in psychology, and most PhDs, is that cohorts are pretty small. And the luck of the draw was that I was the youngest in my cohort, and the only overlap in our life stages was the PhD, right? Most of my cohort was kind of married, having kids while doing their PhD, and I was like 21, starting my program, moving from Miami, Florida to Ann Arbor. So there was a sense of community lacking for me. And that really got me thinking, well, what if I use social media to build that community? But then I was like, what will I post? And so really the full conscious decision to get on Instagram was to build community, but to also share about my experiences, what I wish someone else had shared, what I wish I had known, and now that I'm here, how I'm dealing with it, right? How am I managing it? Because there's a bunch of people who probably wish they knew things, but they didn't, and they're here now. So how can we in this context kind of connect and validate one another and normalize some of what's going on in this process? Plus it's
That's
fun.
great. Yeah. And you said you're creative and it's an outlet for that.
Yes. I love to paint, and I don't have time in, between clinical work and dissertation and internship applications. I think it's kind of fun to make the aesthetic posts and to make the reels. And I think one day I'll look back and be like, wow, remember when you were in it? Remember when you were just so stressed out, or you were just happy to have a croissant from Trader Joe's, and that was like the highlight of the week.
Yeah, absolutely. That's great. It's like a live timeline and like a digital scrapbook, but it's so meaningful on that journey, like you're tracking it.
Yeah, it's like a little capsule. And there's many people along in the ride, right? We're all doing it.
Including Lily.
Yes, my puppy.
Yes. Hey, they're great. What is it? Kapapoo?
A Cavapoo. So a Cavalier King Poodle mix. Yep. She's my dissertation puppy, which my supervisor thought was hilarious, because when I told her I'm going to get a puppy for my dissertation phase. She was like, you and
Yeah.
everyone else. I was like, what? She goes, it's a stereotype. It's a running stereotype that people, because you're home, you're on your laptop,
Yeah. Okay.
you have your little companion. Hmm.
Very interesting. Okay. I guess that does make sense. I mean, people got pets during the great COVID era as well, but
The great COVID era. Yeah.
yeah. No, I had my mom's Yorkshire Terrier Maltese mix would sit in my lap during grad school, and so I would say my dog was like an actual educated dog. It's like, wow.
Yeah. Yep. She'll be
So,
probably my little dissertation credit. Like, thank you to my supervisor. Thank you to my family. Thank you to my puppy who never left my side while I was writing all these long, long papers.
right. And it's cool to hear about your dissertation too, about the interest on body image and family. And it'll be fascinating to see when it's published.
Yes. Right now, I proposed in August,
Okay.
and I'm expecting to have my defense probably in July of 2025. That's the timeline. I hope it sticks. But yeah, I think it's funny when I think about how I told you the interest really burgeoned as a fitness instructor.
Right.
People coming up to me and saying, "Oh, I feel really motivated and it feels different than other classes." Telling you like, "Oh, we're here to burn off the weekend." That creates guilt and shame. Like you come in and it's energetic and it's fun and it's motivating because of these types of things that you say. And now that is my dissertation, like the things that are said within family systems to foster positive body image.
So amazing. Give us an example. Do you have any, like, what stuff actually fosters positive body image in families?
Well, some research suggests, a lot of research suggests that health focused versus weight focused type of message
Right.
is the best thing that you can do. So rather than focusing on appearance, really thinking about the function of the body, appreciation for what the body can do for you. And so when there's kind of complaints or shortcomings coming from, dissatisfaction, really trying to redirect it in a way of, well, it sounds like you don't have as much energy as you would like to do the things, rather
Right.
than wishing your body was a different shape. But then there's also, and this is more so the model I've been exploring, this avenue of acceptance and challenge that falls within confirmation theory. And it's the idea that individuals have a need to be validated. And you can do
Uh,
this through emotional support or just kind of instrumental support. And so when a mother and daughter, for example, are having conversations about appearance, body, diet, taking a stance of how can we open up the conversation in a non-judgmental manner to figure out either how to emotionally validate or critically think through this, there's better outcomes.
yeah, absolutely. And it sounds like you're removing a lot of the shame in those kind
Yeah.
of conversations.
Hmm. Yeah. That would be pretty disconfirming, right? Shame
Mhm.
and guilt shut a conversation down, whereas to confirm and validate opens a discussion.
Of that. I can't wait for you to take your hard, cleaned insights into the field.
I
Already
cannot
doing
wait.
great work with that. So, speaking of our field, what are some things that you think, like, some differences between Gen Z or millennials in their views about psychology or the older generations?
I think capital S, capital M, social media
Uh-huh.
has made psychology much more accessible for younger generations. I also think that this can be positive and negative, but I think perhaps with older generations, mental health and psychology is more often stigmatized, whereas with younger generations, it's welcomed with a big hug, open
Right.
arms. A lot of people in the current zeitgeist, really are looking for labels
Mm-hmm.
to provide stability in a very confusing world. And I think this is very different from older generations where the context didn't it didn't necessarily, what's the word I'm looking for? Precede that need.
Yeah, I think there's ways of going too far in either direction. So the prevalence inflation hypothesis tells us that sometimes mental health awareness efforts can backfire and cause people to interpret normative distress, so normal mental health distress, as like full-on pathology. It's like, well, how useful is it to start labeling yourself? It isn't always very. So how do we balance between a sort of boomer view of just pick yourself up no matter what the circumstance, and then a view of, okay, so I had an anxious moment. I need to go down the rabbit hole and start living life based on that.
Yeah, right. It's like mental hypochondrianism, right?
Yes.
So, I think things could really change if people understood that a lot of the DSM-5 classifications, they try and give a label and a classification for systemic purposes, but really mental health exists in a dimensional way. Everyone is anxious at times. Everyone gets sad. Everyone has to grieve at some point in their life. Everyone loses focus at times. It is normal. We only diagnose when those experiences are so frequent, so intense, and distressing or getting in the way of adaptive functioning that it is now at a clinically elevated level.
Right.
And so you can have a bout of a few sad days. Doesn't mean that you're depressed, because it's not your typical mood. It's not impacting your ability to, I don't know, maybe get to class or to make friends and be with other people.
Right.
And so I think if people kind of understood, or at least it was disseminated in a way that it was clear that these things exist on a dimension, things could be really different.
Yeah, I think that dimensional awareness is important. I mean, there's the stories of people going to college and then thinking everybody in their family has a mental disorder once they start looking into the DSM. It's like, oh, I see this in that person. It's like, yeah, maybe one or two things, but it's not everything, typically. So another thing I wanted to talk about is what you wish that was taught more in your training, or what kind of things you've noticed that maybe other professions have that you have a passion for bringing to the psychology world.
Yeah. Well, I'd say my training's been quite comprehensive, which is probably why I'm so tired, but I'm grateful for it.
Yeah.
But, outside of the clinical work, I think a major shortcoming of psychology PhD programs is the business side of things, like learning. I mean, essentially, the whole conversation we're having right now wouldn't be happening if psychologists were taught to disseminate content in layman's terms, in ways that were digestible, in ways that were accessible for everyone who needs to know about mental health, which is pretty much everyone, right? So I think the communication and business side of things, of networking and really creating a foundation to connect with the community, is something that's really missed out on. People, how do most people see a therapist? Probably in private practice. Never have I learned about private practice, how to start one, the model. It's never been a part of our training, and so that can be very problematic, because then you have the people who are experts and they only know how to do articles, or maybe be in a hospital in the environment that's more gatekept. I don't know.
Yeah, I think that's it. Gatekept for sure.
Versus accessible.
Yeah, absolutely. I mean, there's what you would call the professional orientation classes, and sometimes that's more about what things can look like ethically, or some concerns with business stuff. Very little financially, if any, is mentioned. And so I think,
like insurance.
Yeah,
Sorry,
absolutely.
I didn't mean to cut you off.
No, you should. No, preach.
That's something that we're trained. Look at the DSM, assess what's happening here. And like how I just spoke with you, everyone gets anxious, everyone gets depressed. Doesn't mean that is necessarily that person's meeting the criteria for a diagnosis. And as a
Right.
clinician, I truly believe that. And if I were to be in private practice, some insurances require a diagnosis in order for there to be billing. So then you're kind of giving someone a label so that they can use the insurance.
Right.
Now they have a label that maybe doesn't necessarily represent what's truly going on. Who knows how they're going to internalize that? But it's what's allowing them to get insurance coverage. So it's like, it's a gray area of, as a clinician, maybe it's not the most accurate, but as a mental health provider who wants
Right.
to give access to care, that might be what's best. I'm not there yet, but I think these are the conversations that need to be had when people are in grad school.
Yeah, I think they need to be aware, you're right, of what diagnoses are available to clients. I mean, everything isn't adjustment disorder. I mean, adjustment disorder is quite prevalent. I mean, just by nature, people trying to adjust from massive setbacks. And I think psychopathology class can do some of the lifting there potentially if they just even add in a section into a chapter or module about, okay, and this is what it looks like in private practice. You know, a lot of my colleagues have worked at kind of in community mental health before going private practice. And that's where you see a ton of clients. You see very different levels of support needed or not in clients. Like some people need minimal support, some need a lot of support. And then you gain a lot of awareness in that setting and then go to private practice. But should you have to do that? I would argue no. You should have a really good exposure to what is waiting for you out there up front from people who have been there. It's interesting. We're such a social, empathic field, but then our own training is probably lacking in that department. I will just say on the counseling end, I won't put it on your profession. I'll say I think we need to do a better job as counselors of explaining it to the next generation of what that field looks like.
Right. And there's that distinction between counseling and clinical psych where our training, despite the fact that we might, well, I'm not a therapist yet, but in like 10 years, we'll both have that same title, but my training is very different from yours.
Yes, say a little more about that. That's a good jump off point.
The alphabet soup of therapy.
Yes.
Yeah. Well, we're trained with different models at the get-go. And I don't know how it is for you guys with like practica experiences, but I've definitely been exposed to more inpatient than I have to community mental health, despite the fact that presentations can be the same in either. But yeah, sorry. You asked me another question and it'll help me reorganize my thoughts.
No, I love that. I hear the alphabet soup thing. So for listeners, what that basically means, like there's LPCs, LMFTs, LCS, social workers, licensed marriage and family therapists. I'm an LPC, licensed professional counselor. So for one thing, people are always interested in the differences. Psychiatrists go to med school, psychologists you typically get a philosophy doctorate or psychology doctorate, PhD versus PsyD. And counselors, therapists, typically go get a 2-year master's. Now, that's what I did, but I did a lot of training on top of that in different models like EMDR therapy. So, med school is a certain amount of time, psychology, doctorate, like that's 5 years, right, is what you're doing. And that's what's pretty typical, isn't it?
It ranges between 5 and 7 years.
Okay. So that, and then like 2 years. So you kind of have a different level of training and different emphases there. But I think one thing to consider is there's not always as much of that practitioner scientist model in counseling programs. I opted to take some electives that put that in. But for your program, that's really emphasized all the way through, right? Is being a scientist and a practitioner.
Yes. Okay, so I've regained my clarity and my focus.
You're great.
So, a major difference is that, like the scientist practitioner model and like the emphasis on research and evidence-based practices versus a more humanistic, person-centered approach. Now, something I learned in the past year is that there can be some pretty strong feelings about these differences between the fields.
I'm ready. Let's make good radio.
Well, I told you about this last time. I had taken an addictions class in my winter semester of this year. And I had taken this addictions class that was offered through the counseling and leadership program versus the clinical psychology program because of Florida licensure. I was pretty set on getting back home and maybe practicing at a master's level there while I applied for internship. It didn't happen, but I still learned a lot from just being in this addictions course, which was mainly counseling students. And there was this one day that I will probably remember for the rest of my life where the professor asked about why some people are more predisposed to developing an addiction versus not, even with the same level of drinking. We had to participate, so I raised my hand. And using the biopsychosocial model that I'm trained with, I start talking about the biological predispositions of addictions and kind of the context and how the combination and interactions between the, individual level with the biological and physiological pieces can interact with the environment, right? So I go into this whole thing about that. And this one girl, you're the psychology student, right? And I'm like, yes. No, such a psychologist way of answering that. And I was like, yes. And is there a problem? Counseling stems from psychology. So what's the problem here? And it turns out that with the clinical psychology, we tend to approach through like a medical model. Whereas a lot of counselors do not, or at least the ones that I was in the classroom with were. So that model of understanding and conceptualization can be vastly different between the fields, I suppose.
Yeah, no, I love that. It's a good mic drop. So, I hear that. I remember the first time I heard that and I was like, okay, I like that answer. So I think we need to look at the divisions in the field critically, be critical of how critical we can be of each other, and saying things about the physiological predispositions to addiction. It should not just mark you as being a psychologist. A good counselor should know that stuff. A psychiatrist, whatever. We should all have some awareness of that truth. Now, how much a psychologist gets into that versus a psychiatrist versus a counselor can vary, of course. But I think we as counselors, and again, I'll say this and speak for my field, do not need to be anti-medicine or anti-research, because if we are, then nothing's guiding us but our own presuppositions and our own agenda, and that can be very dangerous. So we should be aware, like, some people are going to be able to drink casually and some will struggle much harder with that. And understanding that does not make us genetic determinists or fatalists. It just means we're well informed. So
ideally, these models should kind of coalesce.
I love that term. Yes. Into the biopsychosocial model of and spiritual. I heard somebody turn it into biopsychosocial spiritual, which is like all encompassing. Yeah, I agree with you. And we should be very congenial, but I think for different reasons, people can feel that a field is kind of foreign to them and it doesn't really resonate and it's cold. And it's like, well, actually, it's amazing. Psychology is a pretty young field, and beforehand, it was seen as less academic than medicine. So anyway, we're all kind of in the healing realm together and need to act like it. So, I'm glad you took some addiction class. I hope you got some good out of it.
It did. I did. I learned a lot about motivational interviewing, and I actually have a few clients in my caseload struggling with addictions, and I'm very grateful that I somehow was in that class. Yeah.
Love that. Yes. So what do you think about CBT, cognitive behavior therapy? What do you wish more people knew about that? Okay.
CBT is a good evidence-based treatment for the treatments that research shows it's good for. People who have distorted thinking, and that being, if someone's anxiety is rooted in distorted thinking, CBT is the treatment.
Okay. Love it. All right. And what are some pet peeves or some things you've heard about CBT and other therapies that you wish people didn't believe?
I wish that people wouldn't say, sorry, my puppy has awakened.
That's great. That's
She's
fine.
gonna join now.
Photo bomber. That's great.
Hi. I wish that people would not say that CBT is gaslighting
Okay.
because it's not. In fact, I would almost say boldly, it is the opposite because our brain is, or not our brain. I don't have too much distorted thinking, I don't think. But people with distorted thinking are being gaslit by their brain. Their
Oh,
brain,
I love that.
their brain is catastrophizing, overgeneralizing, casting blame in a way that is altering their reality. That's gaslighting.
Yes.
And so CBT is grounding them in what the reality is to the objective observer. That is the mechanism through which it reduces anxiety and or depression, not by changing the way you think. And I think that's where the problem comes in, the sticky issue of people believing CBT is just arguing against your thought. That can be a component of it, but that's not what it is. It's arguing against a distorted reality that your brain has created.
Boom. I love that. It's so crucial as a difference. Yeah, when we heard like the trend of CBT's gaslighting, it's like, okay, well, it's not. And, that term gaslighting can be really cheapened by that because, it's originally referring to making someone question their objective reality, but making someone question subjective fears, worries, irrational thoughts is the furthest thing. I love that you said that exactly right. Like CBT is opposite of gaslighting. Right. So we have to go into the uncomfortable questions sometimes and in therapy explore, like, what am I taking for granted and believing that may not be true? And it could be uncomfortable, but it's not. It's certainly better than living a life of avoidance or uncritically following your thoughts, which can be misleading.
Right. And
It's very interesting. Go ahead.
well, what I was going to say is, again, I think this is why it's imperative to really understand the theoretical underpinnings of a treatment.
Mm-hmm.
What are the actual mechanisms of change? Because we're not just slapping on a Band-Aid on someone who has a cough, right? Band-Aids are good. We like Band-Aids. They can protect an open wound. But if someone has a cough, you're not just giving them a box of Band-Aids and saying, here, and this is part of the first aid kit, right?
Right.
What is it about a Band-Aid that supports an open wound? Well, it protects it from dust and other particles getting in, right? What is it about this person's anxiety that needs to be treated?
Mm-hmm.
And what is it about these various potential practices that specifically targets that root so that we can have a mechanism of change?
Yes, absolutely. And with CBT, what would you say that is?
I would say that it has to do mostly with the distorted thinking or
Right.
belief systems that are rooted in distorted thinking. A lot of times, it comes from generalizing. Someone had one really bad experience. Now they
Mm-hmm.
generalize it to everything. Now they're socially anxious, right?
Right.
CBT can take that spin of, well, you had one bad experience. Really, are you catastrophizing? Really, what are the signs showing the evidence for, the evidence against? Really, what are the chances that that exact thing is going to happen again?
Right.
Really, what are the chances that that was your fault and not just the fact that that person was having a bad day?
Right. Love it. Yes. So questioning those suppositions, and then with something like EMDR therapy, it's understanding that traumatic memories are typically experienced differently than just semantic memories, and that we want to reduce the disturbance of those. Like, that's our mechanism of change. So very cool. Love that. Well, what's a day in the life like for you? I know you talked with me a bit before about the CAPS
Yes.
work and what that's like. And CAPS, what does that stand for? The counseling at, or
Counseling and psychological services. Every
Amazing.
university has one. Yeah, each day for me, quite honestly, is different, but I am spending 3 out of 5 weekdays at the University Counseling Center. So I'm working with university students, meaning a lot of young adults, but I also have some clients who are in their late 30s, non-traditional students, and working within a brief therapy model for the students at my school.
Yes.
This includes individual therapy sessions. I also have multiple supervision meetings to discuss the clinical presentations and my approach, get, more perspective, more expertise from people who are already licensed, and also crisis, having a time slot for crisis sessions where people are coming in with high risk, high urgency, and really what we're doing is safety planning.
Love the bug. Yes.
Yeah, she got a haircut. And then I
High
come home.
risk.
Yeah, yeah. Then I come home and I take care of her. But then, with that, there's something to be said about the fact that she's just going to be a part of this now.
That's
Uh,
great. The paw waved.
So with that, there's kind of the work day is clinical in nature. The 2 days that I'm not at CAPS, I'm in a psychometry position, just so I can keep my assessment skills sharp. Psychometry being like I just administered a test battery without necessarily having to interpret and diagnose.
Okay.
But after my clinical work, then it's dissertation work or internship application. And I think that's the hard part about a PhD. I think it essentially you're working full time or learning full time and then trying to make progress on multiple independent projects.
Right. Well, what do you do as we kind of wind down here? It's very informative. What are some ways that you like to stay sane and touch into some self-care?
My puppy.
Right. That's easy. Yeah.
Yes. So she is definitely my little dopamine boost at the end of each day. But I think it's really just important to stay connected with people who are close enough that they understand, but distant enough from the program that we don't fall into the rumination cycle. So really building community through activities that are that promote mindfulness, right? So like yoga, not able to think about dissertation when I'm like bending over backwards.
Yeah, probably not.
Or even this weekend, I'm doing like a pumpkin carving little party just to do something fun with my hands, with my friends, and have something to look forward to. And it will be great. It's just things, I think little things like that is what I think keeps people in PhD programs sane. Like just some rewards, because it is a system that rests on delayed gratification. You have to find ways to give yourself gratification.
Yes.
Something to look forward to.
Preach. Absolutely. Just spots of self-care, tactical places to take rest and rejuvenate. Love that. And not toxic positivity. I know that's a thing you don't like either. We talked about that, which I love. I love addressing that.
Right. It's like the yin and the yang. Like there's good, there's bad. There's bad in the good, and there's good in the bad. And to try and ignore the bad and the good, or the bad altogether, leaves you kind of missing out on life. Like you can't appreciate
Yes.
It's just, it all goes together. It all goes together.
Love that. Well, this has been fun. Is there anything you want to tell listeners about, like any upcoming Instagram projects or video or anything at all? I'm just kind of tossing it to you if you have anything you want to share about your own work, social media wise.
Yeah. I mean, like I said, I'm applying for internship right now. So things have been slow, but I am looking at integrating more of my personal research with the content I create. So I'm kind of planning out like a series on body image in grad school. Talking about the prevalence and how it impacts students, factors, and just ways to manage. But I'm hoping that my content pretty soon can shift one thing I really want to do once I'm done with my applications, I want to start doing like a mental health Friday type of post, because I have noticed a lot of recurring themes. Now that I have a full caseload with CAT,
Yeah,
there's kind of things that are just coming up over and over and over again. And I want to start disseminating therapeutic content in bite-sized pieces, because my content
right,
is for students and I'm working with students 25 hours of the week. Anyway,
right.
long-winded way of saying I'm hoping to post
Love
more
it.
about mental health.
No, that's great. That's what I do. I'll do some videos on that from stuff that comes up that I think to share. So that's a good way to do it. Yes. Okay. All right. That is really awesome. Thank you so much for joining.
Well, thank you for letting me yap about clinical and professional stuff.